Hello, distinguished expert. My name is Zhang-ID87. I'm from the first affiliated hospital of Fujian Medical University. The topic of my poster is laboratory detection of antibody in IIDDs. Idiopathic inflammatory demyelinating disorder are difficult to diagnose. Laboratory detection of antibodies is the key to diagnosis IIDDs. However, the roles of these antibodies for diagnosing disease are in different evidence-based levels. Due to the distinct antigenic properties, they involve various immunoassay strategies. And AQP4 antibodies are diagnostic antibodies. Cell-based immunofluorescence assays are recommended as gold standard of antibody detection. More IgG-associated disorders have various clinical phenotypic spectrum, which limit performing evidence-based diagnostic study. Therefore, mock antibodies can only be used as a disease-associated antibody. GFAP IgG is difficult to detect because of 10 subtypes at least. Therefore, CBA is equipped to detect AQP4 antibodies, but GFAP antibodies versa. Therefore, a combination of more immunoassays are required in the case of GFAP IgG. The human three genes were respectively expressed in the 293 T cell line. Expression of three proteins were confirmed by Western blot. CBA was used to test the IgG of patients, which revealed a positive staining pattern. The positive control used the commercial IgG specific for AQP4, MOG, and GFAP. For GFAP antibodies, in addition to the application of CBA, we also performed detection by immunohistochemical assays. U251 cell line also demonstrates a positive result. However, with the three aforementioned assays, we were still unable to determine the specificity of the GFAP antibody, whether it was combined with other autoantibodies. Therefore, we used the CRISPR-Cas9 technology to construct GFAP-KO mice to perform tissue immunofluorescence experiment. We tested 311 patients for AQP4 and MOG antibodies, with positive rates of 40.2% and 14.1% respectively. The positivity rate of GFAP antibody was 3.1%. In conclusion, we standardized detection strategies of three antibodies. For AQP4 antibodies, a positive result makes a definitive diagnosis based on meeting one of 6 core clinical characteristics, while in case of MOG antibodies, a positive result must be combined with the clinical presentation and the pathogenicity of the antibodies to make a diagnosis. Finally, the diagnosis of GFAP astrocytopathy should be used a combination of detection methods. The pathogenicity of GFAP antibodies deserve further exploration in the future.